So I'm Dr. Jim Del Rosso here in Las Vegas, Nevada. I'm the editor-in-chief clinical dermatology at the Journal of Clinical and Aesthetic Dermatology, and I want to give a call out to our aesthetic editor, and that's Dr. Phil Werschler, who also works on the JCAD, but on the aesthetic side. And I'm very excited about the October 2024 issue. It's finally cooling down a little bit here, getting into the fall in Las Vegas. It still gets over 100, but it's not 115 or 120 anymore. It's NHL hockey season. Very excited about the NHL season with the Golden Knights. Hopefully, we'll win a Stanley Cup again, but it's a tough season. There are a lot of great teams. But this month, in the Journal of Clinical and Aesthetic Dermatology, the JCAD, the Green Journal, as many affectionately call it, we have some great articles. I want to start by mentioning my editor's message, which does give recognition to the loss of a giant in dermatology, Steve Clark, who is really an individual that put Galderma on the map and also rosacea as a disease state. He was involved with the development of and bringing so many things forward and helping so many individuals and supporting dermatology. Metrogel, Cetaphil, he brought that forward significantly. Differin, right, and many others that came to the forefront. And then after leaving Galderma, he was the one that put CeraVe on the map and was involved at Coria and then Clark Dermatology. He unfortunately left us recently. He was a great friend personally and a tremendous person for dermatology, a big supporter of our specialty. So we're thankful for what he's done, and our hearts go out to his family. Fortunately, he did live a long life, but he did succumb to chronic pulmonary disease, pulmonary fibrosis, which his mother had. So, Steve, we'll never forget you, even though you're no longer here. The physical Steve Clark will never forget what you've done. So now I want to talk about some of the articles. And the first, I think, is a great article, which is a cross-sectional study conducted by the National Psoriasis Foundation. The lead author is Melissa Zundell, with several other authors that come to us from three major institutions that we're aware of: Department of Dermatology at the Icahn School of Medicine, Mount Sinai in New York. We have the Department of Dermatology at Brigham and Women's Hospital at Harvard Medical School, and then also from the Cleveland Clinic in the Department of Rheumatology and Immunologic Disease, the authors from there, and from the National Psoriasis Foundation. So this cross-sectional study, which really focused on looking at some patient-reported outcomes, was conducted by the National Psoriasis Foundation, and it included 2,196 patients with psoriatic arthritis. And it really was to look at patient-reported outcomes, but it was the diagnostic delay that was focused upon. The diagnostic delay of psoriatic arthritis of more than 6 months contributes to poor outcomes, looking at things like depression, looking at the individual's willingness to participate socially, and also just their overall sense of well-being was looked at. So really what I believe is important about this particular publication, and I appreciate Dr. Joseph Narola and Dr. Alice Gottlieb, who are authors, uh, you know, wanting this to be published in the JCAD, and we're very happy about it. This was a cross-sectional study conducted by the National Psoriasis Foundation that really focused on finding out from the patient how they felt. And it was based on diagnostic delay. So from the time that the patient developed symptoms of psoriatic arthritis to the time that they were actually diagnosed with psoriatic arthritis. This showed that it didn't take very long before you started to see an increase in depression being reported amongst these individuals, along with some other adverse patient reported outcomes. And these are things that we encounter but sometimes might miss in our patients. And 6 months, to me, that's what grabbed my attention as not a very long amount of time that the patient, has the symptoms and then a delay to the diagnosis. It sometimes takes a lot longer before that diagnosis is made. So they showed that if that delay was less than 6 months, it was about 28.6% of the patients that reported associated depression. So just shy of 3 out of 10. And then when you went from 7 months out to a year, a little bit higher at 29.6%, basically 3 out of 10. But between the first year and the second year, it jumped to 38.1%. So about 4 out of 10. And when you went beyond 2 years, the numbers continue to increase. So now the patients are dealing with the disease and the depression associated. It increases significantly in these patients. To me, that's a very, very important finding. I would check out this article if you are at all interested in psoriatic patients. Many of them do have psoriatic arthritis. The next article is from Juan Gabriel Vasquez and other colleagues who come to us from Granville, Michigan at West Michigan Dermatology, the University of California, San Francisco, and also from Therapeutics Clinical Research in San Diego, with support from some pharmaceuticals. And it was related to a study, a real world study, and real world in the sense that we're not looking at parameters that we do in pivotal trials that are not necessarily what we capture in the real world, like some of the methods like even PASI score is not necessarily done routinely in the real world. We may do global assessments and even some of the other assessments. Here we're looking at the patient reported outcomes where the patients, as they would come back to see us, would tell us about things like itching, pain, the amount of scaling they're having, and also treatment satisfaction, how satisfied they are with the treatment. So these were patients that received the IL-23 monoclonal antibody, tildrakizumab, which is approved for moderate to severe plaque psoriasis. And these were patients that were treated in an open label fashion out to 64 weeks. So there were 45 patients that actually they captured out to 64 weeks. And essentially what they showed was by 4 weeks, there was improvement in these parameters, and that continued to increase over the course of the study. And out to 64 weeks, the improvement that they achieved was maintained. And many of these patients had significant treatment satisfaction. The treatment satisfaction was captured by 3 different rating scales. So remember, the patients are completing these surveys. This is information from the patients. No, there's not a comparator arm, but it's looking at treating a patient with a given therapy with a certain intensity or level of disease in the real world. So this, to me, was a good example of a true real-world study. The next paper is by Larry Green, who is in Washington, D.C. area, a dermatologist there, who I know very well, along with several others that I work with on this particular formulation. I recognize Hillary Baldwin here, Jeffrey Sugarman, Neil Baccia, Phil Werschler, as well as others that worked on the development and the pivotal trials with microencapsulated benzoyl peroxide 5% cream, which is actually FDA approved under the brand name of Epsilay for papulopustular rosacea in adult patients. And we don't think about benzoyl peroxide for rosacea because many of the formulations and how it was formulated, even attempts that try to improve tolerability and was certainly helpful in acne, alone or in combination products, tended to be too irritating in patients with rosacea because of the nature of their skin being a sensitive type skin because of the pathophysiology of their disease. We already knew from some studies that benzoyl peroxide was effective for rosacea, but until we got the microencapsulated benzoyl peroxide 5% cream formulation, the microencapsulation technology greatly enhanced the tolerability and also the efficacy of the product was shown. So in the pivotal trials, this was shown to work extremely fast and had very high levels of improvement by global assessment and inflammatory lesion count reduction. Now, this study looked at the microencapsulated benzoyl peroxide, the efficacy and the safety, and I'm going to be very excited about this because I now fall into one of these groups. They looked at it in the patients below age 65, the adult patients, and then those that were 65 years of age and greater, and showed that the efficacy and the tolerability were essentially the same in both of those groups. Sometimes we say, well, that's no big deal. We know that's going to be true. These assumptions don't always turn out to be true. And I'll talk to you about another example of that in other articles. It's nice to have the data to show that the efficacy, tolerability, and safety are the same in both groups. So let's hear one for the geriatric crowd, the people that are the Medicare age over 65, like myself, right? Very important for us to do these kind of evaluations, right? Next is something I think is extremely interesting, especially when we think about pediatric patients, but it can be used in any of the patients. It's vibration anesthesia. The article is a meta-analysis, vibration anesthesia during invasive procedures from Stephen Comite. I hope I said his name right. And these are three authors from the New York area. He is from the Icahn School of Medicine, Department of Dermatology in New York, and the other authors are from other institutions in the New York area. This is a very important paper. I first learned about vibration anesthesia from Roger Seeley, who was a well-known dermatologist and dermatologic surgeon. He actually is the special section editor of the surgical pearls component of Journal of Clinical and Aesthetic Dermatology. He has a plethora of surgical pearls from his experience, and he's the one that taught me about vibration anesthesia with a very inexpensive tool that you hold on the skin near where you're going to give an injection. And that vibration clouds the nervous system in the sense that you don't feel the pain associated with the injection. So this article addresses that many dermatologic office procedures, whether you're injecting local anesthesia, you're injecting botulinum toxin or a filler or something into the skin, corticosteroids into a keloid, or even doing venopuncture, that there's pain associated with the needle. There can also be pain associated with the actual formulation that's being injected, or the compound itself, the volume of that product. If there's a larger volume, it could be more uncomfortable. So having that vibration nearby is very, very helpful. And this article, this meta-analysis, actually was able to find 35 relevant articles. There are a variety of different instrumentations and techniques that were used. It was not standardized. It was collected from several different articles. But it certainly established that vibration anesthesia is something that you can do in the office to reduce the pain associated with the injection and be done in a way that's not frightening to the patient. Remember, pain associated with injection sometimes is related to the patient's level of anxiety or their pain threshold or their own perception of pain threshold or the injection itself for the reasons that I mentioned. Take a look at this. If you're not using vibration anesthesia in your practice, it is very worthwhile. Now, the last paper is by Miguel Aristizabal, right? I hope I said his name right. And he is the lead author, along with several other authors that come to us from the Mayo Clinic in Jacksonville. And this was a retrospective matched cohort study from the single institution that looked at disparities in basal cell carcinoma. And what they decided to do is to compare two different groups, Hispanic and non-Hispanic white individuals. Certainly, anyone can get a basal cell carcinoma. And they elected to look at this and had 320 patients in both groups based on this particular analysis, a retrospective match cohort study. Now, the authors admitted to making an assumption, the assumption of poorer skin cancer outcomes among the Hispanic group. Right? And this shows why we do studies, because sometimes our assumptions, which are just things that are perceptions in our head that we believe to be true for whatever reason, our own limited experience, or just what we've read or perceive, don't always turn out to be what we find in a study. And what they basically found here is when they looked at, for example, what type of basal cell carcinoma, the most common was nodular, and it was about 50% in the Hispanic group and about it was about 55% in the non-Hispanic white group, very similar. And the most common area was the H zone of the face. So lateral portion of the face and then crossing over the middle on the nose and the cheeks and lower forehead area where we see many of the basal cell carcinomas, and certainly many of them are on the nose. So the H zone of the face was basically the same in both groups. Even the size of the basal cell carcinomas were very close, but tended to be an increased size in the non-Hispanic whites, right? And we know that this can be certainly variable, but it really shows us the importance of not making assumptions of things that we think we're going to see or not see. I think a big one is gender. We hear that a condition is more common in females than males, and then we start to think we're only going to see it in females and not very often in males. That's frequently not true at all. Most of the conditions that we see, with a few exceptions, are seen fairly commonly in both. So I think this was an excellent article. And if you're interested in basal cell carcinoma, I would pay attention to it because they did a very nice job and admitted up front versus some of their perceptions how the results turned out. And that's always commendable with the authors. So that wraps up our October edition. And I hope you find these papers valuable. Contact us and let us know what you think of the Journal of Clinical Aesthetic Dermatology. If you have a letter to the editor, you want to comment on something, be sure to send it in. And we always love hearing from people that read our journal.